Assalamu alaikum. It's your DrNAS, and we are again here with a new topic of valvular heart disease. It's mitral stenosis. So in today's topic, we just cover the first of all the anatomy of the mitral valve apparatus. That is, what is the mitral valve? What are the characteristics of the mitral valve? What are the anatomical features of the mitral valve, and then we will move towards the causes and the etiology of the mitral stenosis, and then we will move towards the natural history, how mitral stenosis develops, how mitral stenosis causing the symptoms of this in mitral stenotic patients, and what is the normal area of the mitral stenosis, and what are the gradients and how these gradients works actually to developing the disease of mitral stenosis. So without wasting the time, we have to first elaborate that what is the mitral apparatus, what is the mitral valve. Mitral valve is not just the two leaflets which are moving between the LA and the LV, but it's the whole apparatus. It is the whole you can say there's a whole machine which is actually working in between the LA and the LV, and it is taking blood from the pulmonary veins from lungs. This is the pulmonary vein from lungs, and taking the blood in the LA, and then this blood is shifted towards the LV, which will transmit it across the aorta in systole, and diastole the blood from LA moves towards the LV. So what is the mitral stenosis? The stenosis is actually the stenosis, as its name shows that there is some stenosis across the mitral valve. So causes could be anything, but there is stenosis. If there would be the stenosis across the mitral valve for any reason, you will label it as a mitral stenosis. So here we want to discuss here that what is the mitral valve. So mitral valve has two leaflets. That is the only valve in your heart which has two leaflets, and it is non-semilunar valves. Semilunar valves are like this shape, like lunar shapes, okay, semilunar shapes. But the mitral valve is not like that. Mitral valve has leaflets, okay, but it has two leaflets. But the contemporary of the mitral valve, which is present at the right side of the heart across between RA and RV, is tricuspid valve. It is tricuspid. It name shows that it has three cusps. It has three leaflets, okay, but the mitral leaflet is the only valve which has two leaflets. The number one leaflet is the anterior mitral leaflet, which is longer than the posterior mitral leaflets. So the anterior mitral leaflet is towards the intraventricular septum, towards the aorta, and the leaflet which is towards the posterior wall of the LV, or it is separating the LA from at the posterior wall of the LV, from LA to LV, you will label it as a posterior mitral leaflet. So the leaflet which is attached towards the posterior valve of the LV, or the posterior side of the LA, you will label it as the posterior mitral leaflet, and the leaflet which is towards the anterior lateral side of the, you will tell the anterior medial side of the LA and the LV, you will label it as the anterior mitral leaflet, okay, anterior mitral leaflet, okay. No, the important thing which I want to mention here, that how these leaflet works. So these leaflets are attached with two commissures. There are the two commissures which where these leaflets are attached, or where these two leaflets join together at the edges. So these edges named as or called as commissures, okay, commissures, and the three codi on each leaflet are attached with the papillary muscles which give support and it gives opening and closing to the mitral leaflet. So these are the three cordae, 1, 2 and 3, 1, 2 and 3, which are attached from mitral leaflets to the papillary muscles. So the mitral valve apparatus consists on mitral leaflets, commissures, cordae, papillary muscle, and the part of the LV where, or the LV muscle where these papillary muscles are attached, also included in the mitral valve apparatus. So all these things when come together, they called as a mitral valve apparatus. So how you name those cordaes? There are three cordaes, and these cordaes are named as primary, secondary and tertiary. There are the three cordaes on which the each mitral valve is attached, and from that cordae are attached to the mitral leaflets, papillary muscles, where they give support and proper closure to the mitral leaflet. We called it as a cordae tendini. These are actually the tendons which gives proper closure to the mitral leaflets. Now the most important thing in the LA is LA appendage. Why I am telling or elaborating these anatomy, because in my further lectures I will discuss all these anatomy and all these things with you guys. So I just want you be very clear about the mitral valve apparatus and the structures which are actually involved in the mitral stenosis or the consequences of this mitral stenosis. So just after that pulmonary veins, where the pulmonary veins open into the LA, here there is the dog ear like structure. Dog ear like structure is LA appendage. LA appendage. There is a very narrow opening and larger sac like structures here is known as the LA appendage. And this is the mitral valve apparatus. And if you see from here, like if you are looking mitral leaflets from this position or this position, and if you are looking mitral valve position from this position, you will label it, or you will call this view as a surgeon's view. Whenever surgeon wants to do intervention with the mitral valve, surgeon always takes the surgeon's view. So if you are looking mitral valve from upward, okay, and your mitral valve is just downwards and you are looking like this, you will label this view as a surgeon's view. And if you are looking here, from here, and like if you are here and looking the mitral valve, so if you are in the LV and looking the mitral valve, this view is known as physician's view. So if you are looking the mitral valve from downwards or upwards in a short axis, or you can say that if you want to see the mitral valve as a whole from upward or downwards, you will appreciate that there are two leaflets. This is the anterolateral, this is the anterior mitral leaflet, then this is the posterior mitral leaflet, and there are the two commissures where the anterior and the posterior leaflets joins together, and these are the at the edges where they have the support as well. You will name them, you will label it as a commissures, and the commissures which is present towards the anterior and the lateral side is known as the anterolateral commissures, and the commissures which is present towards the posterior side, its name it is called as posterior medial commissures. Okay, posterior medial commissures. And there are actually two commissures in the mitral valve, and the ring where whole two valves are attached is known as annulus, and this is the fibrocartilaginous ring which gives support to the whole leaflets. It actually holds the whole leaflet, both leaflets, like the curtain like structures. Okay, so this is the annulus and these are the commissures, and every leaflet has three segments. Okay, A1, the three segments of the anterior mitral leaflet is A1, A2 and A3, and the posterior mitral leaflet is P1, P2 and P3, as you are appreciating here that the anterior leaflet is bigger than the posterior leaflet. Okay, so why these are important, we will discuss all these things in the echo segment, because and the TOE and in the TE we have to calculate the Wilkins score, which all these structures we will discuss in that segment. Now without wasting time, we have to, as we I hope that you will you have understood the basic anatomy of the mitral valve. What is the normal area of the mitral valve is 4 to 6 centimeters square, and the normal gradient, usually there is no gradient. Yes, there are few gradients which actually gives some obviously when there would be some gradient in the early diastole, that's the reason that blood moves from LA to LV, but these gradients are usually negligible. That's why just keep one thing in your mind, that usually there are no gradient between LA to LV. Okay, now the important thing is, what are the causes, what are the things which cause this mitral stenosis. So number one, and the most common cause in the developing world, is rheumatic heart disease. Okay, and we have discussed about the rheumatic heart disease in my lectures of rheumatic fever. We have discussed each and everything with the with all that, how this rheumatic heart disease causes the destruction of the mitral leaflet and all these things. So I would suggest you guys that go and watch those lectures for the detailed description of the rheumatic heart disease. So rheumatic heart disease causes, and it is the most common cause of the mitral stenosis. It causes destruction, and when it causes the destruction, okay, how much time it would take we will discuss later on. And the second most is the degenerative, if your patient is older, and the degenerative, like the calcified mitral valve, is usually the cause in the older patients or in the developed nation, because the rheumatic fever is most common in developing nation. And the systemic disease like Fabry disease, carcinoids, systemic lupus erythematosus and other like autoimmune diseases causes the destruction of the mitral leaflet as well, so they can also cause the mitral stenosis. The congenital, the two most common causes for the congenital or in the younger people are the parachute mitral valve. What is the parachute mitral valve? In parachute mitral valve, there would be a single papillary muscle, and there would be a single papillary muscles attached to both. So it causes what? It causes stenosis and inappropriate opening of this mitral leaflet, and causing what? Parachute-like mitral valve with stenosis. Okay, with stenosis. And this is actually very important. Why? Because in that sort of mitral stenosis, the PTMC, the percutaneous balloon, PBMC, the percutaneous balloon mitral shortening is not the option, because it causes this. Usually, it causes a severe MR post PTMC in parachute mitral valve patient. That's why the surgery is the only option in parachute mitral valve. And usually, if they ask you that, tell me the one condition of the mitral stenosis in which the surgery is contraindicated, it is the parachute mitral valve. Okay. So what is the parachute mitral valve? The single papillary muscle attached to the chordae of the both leaflets and causing the stenosis is known as the parachute mitral valve. And the supravalvular mitral ring, if there is any ring present here at the supramitral leaflet, and if it is causing the stenosis, so you will label it as a supravalvular mitral ring, and it is causing the mitral stenosis in the young patient, and it is obviously the second most common cause of the congenital cause of the mitral stenosis. Now, what is the natural history? If my patient has encountered with the rheumatic heart disease, and he or she had that rheumatic heart disease, so how much time mitral leaflet would take to develop the symptoms or to develop the stenosis? It's 10 years. 10 years mitral leaflet needs to develop the mitral stenosis or moderate to severe mitral stenosis once it encountered with the rheumatic heart disease or valvulitis. Now, how if once my patient developed excuse me, developed the symptoms. So what is the survival of my patient? That would be the next question. Then the survival of my patient would be less than 15%. The 10-year survival of my patient would be less than 15%. Like those patients who become symptomatic with severe mitral stenosis, okay, the only 50% of the patient will survive more than 10 years. The rest of the 85% people will die within 10 years. This is the natural history of mitral stenosis. Then the important thing is that what is causing the symptoms of mitral stenosis? What are the things? What is the pathophysiology behind the symptoms, and how my patient are presenting to the emergency room, and why my patient has all those symptoms with which he or she is presenting to me in the emergency room? Number one, and the most common cause, is shortness of breath. Why my patient develops the shortness of breath and he or she is presenting to me in the emergency room? Because of the increased venous congestion. If there is an increased LA pressure because of the stenosis mitral valve, it increases the LA size and transmitting the pressure towards lungs. In lungs, it increases the venous pressure and it increases the pulmonary hypertension and causing the venous congestion and causing the pulmonary edema and causing the shortness of breath. So it depends upon the severity, that how much the severe MS, that the more the MS will be severe, the more will be the pressure in the LA, the more will be the pressure in pulmonary vessels, and the more will be the shortness of breath, because there will be the more pulmonary edema. Usually your patient initially presents with the NYHA class 1 and 2, and then they ended up with proximal nocturnal dyspnea and orthopnea. Number 2 is hemoptysis. Why my patient has hemoptysis with the mitral stenosis? You have to understand it. Again, the same increase LA pressure, increase lungs pressure, and increased lungs pressure causes the increased pressure in the pulmonary vessels, and usually they causes what? They causes what? They causes rupture of pulmonary veins. Whenever there will be the rupture of the pulmonary microvasculature or pulmonary veins, it causes the hemoptysis with the mitral stenotic patient. There are a few more causes with this mitral stenosis, the few more causes of hemoptysis in mitral stenosis patient as well, such as the pulmonary edema. In pulmonary edema, the usually patient has a frothy pink sputum, okay, which sometimes taken as the hemoptysis. Number 3, if your patient is taking anticoagulation or on oral anticoagulation, so sometimes it causes the easily ruptured pulmonary microvasculature because of increased pressure, and it causes what? Hemoptysis. Okay. Now the chest pain. Why my patient has the chest pain? Why? Because of increased RV oxygen demand. Because of the RVH. If the pressure in the lungs are increased and it increases the pulmonary hypertension, so RV has to contract more. RV has to give the more efforts to push blood from RV to lungs, because the here valve is stenotic and it is exerting back the pressure towards lungs, and lungs has more pressure. Now RV has to generate more pressure to send the blood from RV to lungs. That's why RV will build the muscles. RV will do the bodybuilding. Okay, so if the RV do the bodybuilding, or if RV will be hypertrophied, it increases the oxygen demand of the RV, and if RV will not meet the demand of that oxygen, it will cause pain. So chest pain in mitral stenosis is usually because of increased RV oxygen demand. And why syncope? Most of the time patients with mitral valve apparatus presents with the syncope. There are a few more causes. Number 1 is the fixed output, obviously, because there are the fixed output and output is not increasing. If anything occurs or LV needs more blood, so obviously it won't give towards the system, and if there would be no blood, more blood towards the system, it will, or it can cause the syncope. Number one. Number two, there could be the atrial arrhythmias, which can causes the syncope, which is very rare, but yes, it can cause the syncope, because atrial arrhythmias can cause hemodynamical instability in sick patients or in patients with this cardiac shock. Now, hoarseness of voice. Why my patient with the mitral stenosis would have the hoarseness of voice? Because huge LA cause pressure at the larynx, pharynx, and recurrent laryngeal nerve, so it can cause the hoarseness of voice, and this syndrome is known as the Ortner syndrome. Now, what is the why my patient would have the easy fatigability? So obviously, because of the fixed output, if your patient will do the exertion, it can causes the easy fatigability, because the output is fixed, and it is not giving more blood towards your system, which your system actually needs. Palpitations, yes, again, because of the LA enlargement, there would be a stretching of the electrical signals or the electrophysiological tract around the LA or RA, so it can cause the atrial fibrillations, atrial flutters, or sometimes the sinus tract and all these things. So yes, the atrial arrhythmias can cause the palpitations, or your patient may present with the palpitations due to the atrial arrhythmias, and the atrial fibrillation is the most common like atrial arrhythmias with the mitral stenosis. Now, right heart failure, yes, when your right heart will build the muscles and doing again and again and persistently giving and exerting the pressures against the high pressures in the lungs and the LA, so eventually RV fails. Eventually it would be failed, and it causes the RV, right heart failure signs such as the hepatomegaly, peripheral edema, ascites, and all these things. Okay. So right heart failure, again, your patient may present with the right heart failure or symptoms of the right heart failure with the mitral stenosis. If it will be long-standing mitral stenosis and it will not be corrected by anyone. LV dysfunction, yes, it is most commonly asking question that why your patient would have the LV dysfunction if the LV has it is nothing wrong with the left ventricle in this mitral stenosis, because there is the only decreased flow towards the LV, and LV has to work less because LA has to work more. Why? Because LA is enlarged and there is stenosis. LA has to contract, LA has to send the blood towards the LV, so LV has to send just that less amount of the blood which is coming from LA to LV because of the mitral stenosis. So what are the causes of the LV dysfunction in the mitral stenosis? It is the most asking question. Number one is the rheumatic fever. If your patient has a pancreatitis, if your patient has the myocarditis, valvulitis and pericarditis, or if your patient has a myocarditis secondary to the rheumatic fever, your patient may present with the low ejection fraction and as well as with the mitral stenosis. Number two is ischemic heart disease. If your patient has concomitant ischemic heart disease with the mitral stenosis, your patient may present with the low ejection fraction, because there is also a right of the mitral stenotic patient that he or she would have the ischemic heart disease. Ischemic heart disease can be occur with any patient. It can be present with the pre-existing mitral stenotic patient. If your patient is mitral stenotic and he is or she is presenting to you with the middle age, and she or he has this history of premature coronary artery disease, or she or he has a risk factors for the coronary artery disease, he or she would have that ischemic heart disease on pre-existing mitral stenosis. Number two. And number three, because of the decreased work, the LV would go into the atrophy. LV it decreases its function because LA is not sending the appropriate blood volume towards the LV, so LV sometimes diminishes its function and it reduces the ejection fraction. Number four, tachyarrhythmias. Because of the atrial fibrillation or tachyarrhythmias or PVCs, not PVCs, but the atrial arrhythmias, your LV would go into the tachy-induced cardiomyopathy. If the tachy-induced cardiomyopathy will occur, then again there would be the low ejection fraction. So these are the causes of the symptoms. These are the pathophysiologies behind the symptoms of mitral stenosis. In next lecture we will discuss about the clinical exam of mitral stenosis, how to exam, when to exam, and how you would approach your patient with the mitral stenosis in the emergency room. And in the third lecture we will discuss detail about the echocardiography in mitral stenosis, how we will calculate the area and all these things with the mitral stenosis. We will discuss each and everything with it, and the last obviously we will discuss about the management. So hopefully that you will inshallah make your concepts clear with me, and I have made myself clear on these few things with the mitral stenosis. So just please request, which I usually do in the last, that subscribe my channel and spread my message as much as you can. Allah Hafiz. Take care.